Morning, everybody. Thank you for joining us today. We have the team from Montefiore Kidney Transplant here to teach us a little bit about living donation. And I wanted to preface the call by reminding anyone who's on the call who's a registered nurse, LVN, dialysis technician, or dietitian is able to receive CE credits. And they will be receiving an email from me within 10 business days on how to access that certificate. This slide is stating what the learner will learn throughout this course today. And with all, I guess, and some other housekeeping rules, please ensure that your computer or device is on mute so our presenters have the floor to speak without interruption. And then if you have any questions, you feel free to put them into the chat on your screen, or you can hold your questions until the end. We will have a Q&A portion of the session afterward, and I will pass it back over to you guys.
Okay, great. Yeah, so we'll do our best to answer those questions as they come up, but we may get to a few of them towards the end. So just brief intro here. This is our main living donor team. We have Helen Stamey, our nurse coordinator, here with us today. Lindsay, Veronica, the independent living donor advocate / social worker. And then myself, I'm the outreach social worker. So I do a bit of work kind of all over where I'm needed. All right, so brief history. So the first donation was also actually the first kidney transplant between two 23-year-old twins back in 1954. This timeline is just to illustrate the time gaps really in between living organ transplant. Kidney came a full 30 years first, so just to see how that medical process has evolved over time. Just a little bit on allocation here. This information is all available on UNOS. They actually have a really great timeline that you can scroll through. Definitely recommend taking a peek at it at one point if you have time. Just illustrating here, 1950s to the 70s, there really was no organ procurement network. So everything was done by the individual hospital. Led to a lot of errors, missed opportunities. By 1968, they had started the scaffolding for an organ procurement foundation that eventually does become the National Organ Transplant Act organization in 1984. And now we are working, with multiple agencies, IPRO, obviously, NKR, UNOS, to help us organize and allocate offers as efficiently as possible. So just a few stats and trends. For the first time ever, more than 50% of eligible New York adults registered as organ donors. According to a sample of the U.S. population down at the bottom here, it's about 90% of people in the U.S. support organ donation, while only 60 are actually signed up for it. So you see a pretty large gap in between what people are expressing as beliefs and what they're willing to participate in. And then in New York alone, there's about 8,000 people on the wait list. 7,000 are waiting for kidneys, so about 1,000 for other organs. So in terms of transplant trends, you can see from 2001, 2, and 3, it was really the only years that it overtook deceased donors in terms of surgery. Since then, it has basically stagnated. So just really highlighting here the importance of this discussion with our patient population, just to make sure that they understand the benefits and also motivate ourselves to get the word out there. Pretty general chart here. I'm going to go through this one pretty quickly. Essentially, the graph is just illustrating lifespan after transplant. So the orange being your life expectancy while on chronic dialysis, and the blue being your life expectancy once you've received a suitable kidney. So just brief overview here. The main highlights on the benefits of living donation. First, the easiest part would be coordination's a lot more simple. You're not getting a random phone call for a deceased donor. We're able to locate the donor based on evaluation, and we can set a day and a time for the actual procedure, making it a little easier to kind of plan with family, work, and just get yourself organized. having a living donor, obviously the biggest benefit would be the length of time that organ lasts is in some cases more than twice as long as a deceased donor. And it also shortens the timeline for waiting for an organ from what we would consider about 5 to 7, 5 to 8 years in New York, down to as little as 90 days if everything is completed on time. So about 5 to 6,000 people donate in the US every year. We wish it was higher, but again, those numbers have remained relatively stagnant. And then we'll get to this a little later as well. This just illustrated the matching, so understanding exactly where you can donate as a living donor based on your specific blood type. Something to be aware of is if you are not compatible with your intended recipient, there are other options. This is not the end of the road. We want to make sure that you kind of pursue from other avenues as well. So Helen, if you want to just talk about this and the vouchers.
So for patients that are incompatible or anatomically inappropriate donor to recipient, there is something called the kidney paired exchange. There are several of these in the country. UNOS actually has one themselves, United Network for Organ Sharing. We participate with something called the National Kidney Registry, which are programs buy into, especially for their patients that are difficult to match. And there's a variety of ways that this works, but the couple has to both agree to go into the exchange program, and they get registered as a donor and as a recipient. There's advanced donation or voucher donors. We've had a big variety, but it does offer opportunities for more people to get transplanted that have donors that were either incompatible with them or for some other reason appropriate for their intended recipient. It does not occur unless the recipient gets transplanted. I think one of the things that donors are always scared of is that if they, go into paired exchange and they donate their kidney, that their family member or a friend is not going to get a transplant. It sometimes occurs over time. It sort of depends, but we educate them and encourage, patients to move forward with this, because even if you get a kidney from, somebody that's in their 60s, that's a live donor, they've had a very extensive medical workup, and these kidneys do function better and last longer from some of our deceased donors that usually have medical conditions, which is what caused them to have a brain injury.
So I can just touch on this very quickly. So there's a voucher system in place as well. If you are able to locate a suitable donor, but the timeline does not match up for the other recipient, you're able to donate in advance, receive a voucher, and cash that in for your surgery once you have really prepared for it.
And I'll add, I know Helen mentioned some families or recipients, donors, they're afraid if they donate, their family member might not end up getting a kidney or might have to wait long. But I'll give an example of a pair that did use the advanced donation to benefit them. So it was a husband and wife. The wife was the donor. The husband was the one receiving a transplant or waiting to receive a transplant. And they had limited support and young children. So it was not very realistic for both of them to undergo surgery on the same day with young children. So after seeing that the donor was going to go and pass all the testing, she was approved for donation. But the support was the only thing that was kind of tricky. The donor decided to donate in advance. So she donated first. The husband, the recipient, was able to help with the children, help with her. And while they did have some support, it was very limited. So the husband then, after the donor recovered, we activated his voucher and he ended up receiving a transplant a few months after. So I think it's just an example of like a situation where this actually really helped the husband and wife.
All right, so just criteria and risks of donation. So I'll let Helen talk about this as well, because some of them are relative and can be worked on as we go through the evaluation process.
I think, one of the things that's important to remember is that, we do as much testing as possible to ensure that we're protecting the donor medically. And, there's always an emotional component if it's somebody wanting to donate to a family member and they say, I don't care if I have blood pressure, I don't have diabetes, but it's ultimately our decision whether donors move forward or not. So they cannot have uncontrolled high blood pressure. There are certain donors that we consider with high blood pressure on one medication that's well controlled, obesity. We have a program that we work with that is out of Chicago called Project Donor, and their main goal is to work with donors to achieve weight loss goals. They have a grant, I think, is it University of Chicago? I think University of Chicago. And they will even work with them post donation because, it's great to lose a bunch of weight to become a donor, but we want to make sure that you remain healthy after donation. So there are certain criteria that, donors need to meet based on cardiac disease, substance abuse, lung disease, active psychosocial issues that may prohibit them from, having problems post transplant. We know that there's an increase of, some psychiatric illnesses being exacerbated post donation. And of course, no active cancer or infectious disease that would be harmful to them to donate and also for the recipient.
So just some surgical risks here, something that we would highlight for any major medical procedure at Montefiore, but some things to be aware of here. The risk of death is extremely low. As you can see, it's a very straightforward procedure considering what we're doing. And as it says at the bottom, of course, none of these complications are expected.
I think the last donor death was in 2011. So they have made a lot of changes in the surgical approach, which, has increased the amount of living donation because it's a much quicker recovery for donors than it was when they first started doing living donor transplants.
Yeah. So just a little more on medical risks here as well. So some of the short-term recovery can be a little more uncomfortable for the donors in the beginning, basically because of how they take the kidney out, and we'll get to that in just a couple slides. Other than that, just some basic increased risks. We are taking a kidney, and then just education of avoidance of certain, medications moving forward.
So we do a psychosocial evaluation as well as part of the process for the living donor. And some potential psychosocial risks could be dealing with body image. We know that there is a scar after the donation. So we talk about that. Concerns about the recipient. So we do talk to donors about the fact that some donors do experience some symptoms of depression or anxiety after donation. Some of this comes from concerns for the recipient, especially if the recipient experiences any type of complication. Also for themselves, if donors have any complications, that could lead to it affecting their emotional well-being. Also fatigue, pain after donation, that can impact their mood. So we could talk about their current coping skills. What do they do to help cope? And are these things that they can continue to do after donation? So, if someone says, I cope by going to the gym, well, that's something, you won't be able to do for a few weeks after donation. So what else is there that you do now or can think of doing during your recovery period? Also, adverse feelings about being dependent on others. We see often people that come forward as donation are often the helper, the person that takes care of everyone. And we want to make sure that they understand the importance of not taking a step back and not being that person during their recovery period and allowing for others to support and help them during their recovery period. Definitely the no heavy lifting. We don't want them to get a hernia or get any other type of complication. And then also financial difficulties. So we know and we make sure that donors understand that they're going to be out of work for a few weeks. So we talk about employment. Do they have paid time off through their job? And how is that going to impact them financially? There are some resources. So we talk about programs, including the National Living Donor Assistance Center that provides some help to donors, including wage loss reimbursement. So if they do not qualify through their job to get paid time off, can we apply for this program? Are they eligible for the program? Also, we explore external and internal pressures. So are they feeling pressured by family members to donate? Or are they feeling internal pressure, guilt, fear? And we talk through this during the evaluation to make sure that they are donating for the right reasons and that they do want to donate, and not that they're feeling like they have to.
Just a little on the health risks of having one kidney. I'll let Helen speak about this as well.
So we know that 1 in 600 people are born with one kidney, and most people won't know because they have normal kidney function. So anything over 60% is considered normal. When you donate a kidney, you can lose 25 to 35% of your overall kidney function. So that means you need to meet a higher threshold of kidney function to even be considered for donation. We have to allow for that 25 to 35% loss of kidney function. It does not happen to everybody, but we certainly don't want to put somebody in chronic kidney disease due to donation. Depending on risk, risk assessment and family history, they may be at slightly increased risk for high blood pressure. This does not necessarily lead to a bad outcome, but if there's not intervention when the blood pressure becomes elevated and you only have one kidney, it will fail quicker than if you had two. Let's talk about this too.
Yeah.
So there are some safety things in place for donors that are either legal residents or citizens in this country. And if for some reason you donate a kidney and 10 or 15 years down the line, you develop hypertension or your remaining kidney fails for some reason, you do get priority on the United Network for Organ Sharing national wait list for deceased donors. So instead of the waiting time being 4 to 7 years, it's usually a few months. I've worked in transplant for a very long time. I saw this only once, a father that had donated to his son and developed hypertension 10 or 15 years after he donated. That remained untreated due to a lapse of insurance. His remaining kidney was starting to fail, and he got transplanted within a few months of us placing him on the wait list.
So very, very uncommon that we need to use this benefit, but it's nice to have in place. So now we're just going to talk a little bit about the evaluation of donors. From the recipient standpoint, it's pretty much a plussed up version of that. So we have you meet with our main starting medical team, the transplant coordinator, donor surgeon, social worker, and nephrologist. Depending on the assessment, we may need you to see psychology or psychiatry. Veronica doubles up again as the ILDA, and will come in and speak with patients from that perspective as well. We do ask for a very in-depth medical workup, again, to limit any risk that we might see pose an issue for the patient. We want to make sure that everything is as safe as possible for proceeding, especially for like the altruistic nature of this procedure.
And just to highlight, we do, as the first bullet point says, we remind donors that at any point during the process, they can opt out of donation, whether they have started the evaluation or not. Even if they have been approved for donation, at any point, if they change their mind, if anything happens in their life where donation is no longer feasible, they can just let us know, and they can opt out at any point.
So just a few questions for our team to discuss here. So just like Veronica was saying, you are able to opt out at any point. In terms of protecting yourself from judgment, the decision will come from the medical team. We won't make up any diagnoses, but we will be the deciding factor and discuss that with the patient. They will also, as a recipient, will not know that there is anyone in workup for them unless that discussion is had amongst their family.
And the recipient is not entitled to any information regarding the donor workup or decisions not to move forward and why. If they choose to share that with their recipient, that's fine, but we do not disclose anything. If they decide that they want to opt out, that is not discussed with the recipient. So we do everything in our power to protect the donor and any decisions, especially that are unfavorable to, protect their privacy.
So the main risks of evaluation are here. I'd say the biggest one for us that we would see every now and then is that there may be a newly discovered issue in your own health during this evaluation process. I've personally worked with Helen on a case where we had a donor come in and then had to put him into the recipient pool for evaluation because of his own issues. But things like this do happen where patients find out they're diabetic or have other illnesses that we need to address before going through the evaluation process. So there's no cost to donors. This is all covered under the recipient's insurance, workup, medication, and procedure. There is some more coaching that Veronica will go through again with the financial assistance programs, maybe navigating disability at your work, transportation, things like this.
So all donors have to meet and have the right to have a living donor advocate. So I meet with them to ensure that they are receiving all the information that they should to make an informed decision about donation. Helen mentioned earlier, for the most part, you will have family members come in and they are just focused on helping their family member get better. They're worried about their loved one, but we want to make sure that they're able to take a step back and really think about how donation is impacting them. And so making sure that they're making an informed decision, that they're speaking with all members of the team, that they are having all their questions answered, and that they feel comfortable with the process, and that at every point in the process, they are still comfortable to move forward. All of those aspects are important, and that they're able to give informed consent, right? So if we have young donors, making sure that we're assessing their ability to understand, to give informed consent, their level of maturity, etc.
So the surgery itself, I'll let Helen talk a little bit about this, but without our surgeon, we'll keep it a little more general here.
So the surgery itself takes 2 to 3 hours. We know that they're in the OR a little bit longer because of anesthesia and positioning. Typically, the hospital stay is 24 to 48 hours. There have been some donors that have stayed a little bit longer. And their activity is only restricted to lifting greater than 15 pounds for 6 to 8 weeks. Other than that, they are allowed to shower, they can eat, and they need to stay hydrated, but they are tired. So even though there's not much to see on the outside, as when it's a laparoscopic procedure, they do feel fatigued from, being insulted by having surgery. Generally, when, the surgical decision on which kidney we take is based on what the imaging shows, and generally the donor is left either with a bigger or better kidney, and the recipient is given, if it's a smaller kidney, the recipient is given a smaller kidney. So all of that is based on the imaging, which is why we do the CT scan, to look at vessels, to look at volumes, to see if there's any abnormalities in the kidney itself.
Let's skip over the questions here. So yeah, no specialty medications after the surgery for donation. You will be given painkillers and some other meds, but nothing long-term like the recipients will receive. Special diet after donation. We just want you to monitor your basic nutrition, but nothing, again, too abstract there either. We really just want you to improve yourself or maintain healthy lifestyle. We'll talk about that in just a couple of slides. In terms of recipient needing dialysis after surgery, for living donors, this is not the case. So deceased donors may experience something called, or recipients may experience something called DGF, delayed graft functioning, where after surgery they may require some dialysis for a short period of time just to make sure that everything starts to work properly. Living donors, it's working very typically before they're even out of the operating room. So,
as far as having children, we do ask our female patients to wait 1 year. to get pregnant. We want to make sure their kidney function remains stabilized. We know that during pregnancy, there can be, there are syndromes where you can start, spilling protein or develop blood pressure. So we asked them to wait 1 year. We've had some that got pregnant 9 months after they donated and they went through fine, but just for a safety precaution. For men, of course, they're not affected by this.
All right, so after the surgery, follow-up is a lot more simple for donors than it is for recipients. The frequency listed there is pretty spaced apart. We usually see our recipients, just for comparison, about twice a week for the first month, and then build out from there. We do require about 2 years worth of follow-up though. So very standard checkups. We want to make sure that we're monitoring all of your urine and blood levels just to make sure there aren't any decreases in kidney functions. And then returning to work really depends on how physically demanding your job is. Length of surgical healing is, I think, about 4 to 6 weeks for this, right, Helen? Yeah.
6 to 8.
6 to 8.
But we've had donors return to work depending on the type of job 2 weeks after they donate.
Yeah. I have also had patients driven to their appointments by their donor, which is ill-advised, but it happens. So, all right, so this is the basic lifestyle advice, right? I think all of us could probably do well to heed this information. So we really are just trying to help you navigate post-transplant life, being aware that you could have a decrease in that kidney function and walking you through what we could really help you with in terms of benefits to your lifestyle. All right, so getting the word out. This is what our team is good at. So we have a program through our own marketing partnership with a company called Alto, called Live and Let Live, where we help you create videos basically explaining why you want to live, why you're pursuing this surgery, and give information to really just tell your story about who you are, make yourself a little more of a name and not a number. NKR, the National Kidney Registry, has a similar thing with microsites. I believe that Live and Let Live looks a little better, if I'm being honest, but they're both really good resources. Our team is also excellent at coaching. It's a difficult discussion to have. You are talking with somebody, regardless of your relationship to them, about receiving a body part. It can be very difficult to navigate. So some of this information is definitely useful during those conversations, like the safety net that we talked about a little earlier. In regards to getting the word out there some more, you have social media now as a good resource. The Live and Let Live video can be posted on YouTube, Facebook, Instagram, wherever you can post media. And then general community outreach, not forgetting that if you belong to any religious communities or sports communities, really anything in your area, that there's a gathering or some kind of like-minded gathering, just to make sure you're having those discussions as you go through this process. So moving forward, this is just a little bit on what's coming up, really. So as time goes on, robotic assisted surgeries will become more prevalent. So these will help assist us with cutting down on surgical times, intraoperative ease, reduced wound complications and recovery times. And it will also help us with some of our recipient surgeries in regards to their higher BMIs. We do have a cutoff for about 40 on the recipient side for that. And this will just help us navigate slightly heavier patients. So in terms of legislature, this is really the most interesting thing, in my opinion, going on right now, the End Kidney Deaths Act. So generally speaking, this is just an incentive to donate. The government is hoping to get this passed. There was some traction earlier this year. We'll see how far it gets. Basically providing a $50,000 federal tax credit broken down into 5 years of $10,000 credit payments. Really, the idea here would be to eliminate any of the disincentives, so loss of wages, transportation, things like this that might stack up and cause financial issues to the donor, and just trying to free them up for this process a little more. Really, basically speaking, there's a lot of information out here on this, but a couple of the studies have been estimating that It could increase total donor volume potentially by 60,000 over the first 10 years if this is to be implemented. And to put that in perspective, it would save roughly $25 billion in treatment costs, as well as clearly, preventing the possible deaths of 60,000 people. So, all right. So coming up, this is just another event that Montefiore is doing, the Kidney Connectors event. I'll let Veronica talk just a little bit about this.
Yeah, so we partner with the Kidney Connectors. They're coming up March 12th. We're gonna have a pair, recipient and donor, come. And the really cool thing about this is that it's a recipient and donor that kind of run the presentation. So patients that come to this are listening directly from a recipient and a donor. They talk about their experience going through the process and what it was like for them, how they were able to, the recipient share his story or dialysis, get through transplant, and the donor, her decision-making process being evaluated and donating and how she's doing now. So it's something that we are trying to do more, offer these workshops for patients to come and learn a little bit. We know that sometimes listening to us can be, it's better to hear it directly from someone that's been through the experience. So I think that it's really neat to have this for patients to come and listen to.
So just some general info here. Left side is the Center for Living Donation. So we have the number posted there and a QR code as well for ease of access. The QR code's on one of the handouts that we have from the Living Donor team. Just makes it a little easier for the patient to hand that out, or for the person who's interested in a donation to kind of just take in that QR code and get the process started. If anybody is interested in receiving that, you can definitely email it out. I'll put my email in the chat in just a minute. In regards to outreach or center visits, that's the right side. So our general transplant center contact information, and then the coordinators for outreach would be myself in the Westchester Nyack region. Northern, I've been out to Middletown and Beacon recently as well. And then we'll also come and see anybody in the Bronx if you guys are attending from that area today. You're more than welcome to call me. I'm happy to set up for any of the areas that we service patients, not just the ones that I've listed up there. We can do telehealth, lunch and learns as well. If your center is a little further out and has difficulty getting speakers from some of the city centers, Albany or Hackensack, just let us know. But other than that, I just want to open it up for a few questions. So let me just.
Thank you guys so much. If any of our attendees have questions, again, you can use the chat feature, or you can unmute and ask your question directly.
Do any of the team members on the call have that living donor discussions with the patients, or do you typically leave that to the transplant programs and nephrologists? So how does that work for you guys typically?
I talk about it in the beginning when the patients are intaked here. Good morning. I'm at St. Barnabas outpatient dialysis, and basically we give them a packet on transplant, and I'm the transplant little coordinator. So when we go talk about transplant, we do talk about living donor, and then I encourage them when they go to actually have their transplant appointments with you guys at Monty to have more in-depth conversation about it.
Yeah, so that's really how it should be. Thank you for answering. I appreciate that. obviously from the specialty perspective are, capable of coaching. Any amount of information that is able to be like reinstilled into these patients, or just giving them the opportunity to discuss it and have that open air to maybe rethink about the process for themselves at a later date, is really important. I think a lot of what happens with our patients is that they have that thought one time and then reside into the wait time of the 5 years for a deceased donor. But it is something that can be helpful. We've had patients come in for multiple years of evaluations. Third year, they come in after accumulating, 3 years of dialysis time, have decided, you know what, we are actually able to work out a donor. I want more information about this again. So just making sure that that conversation is active and ongoing, I think, is a really big benefit for our population.
One question in the chat is, will you evaluate donors or recipients who are undocumented?
So when it comes to donors, yes, we have and we can evaluate donors who are undocumented. It is not a requirement that they be documented. However, there are certain conversations that are important to have with those donors. One of them being that the safety net is available, but only for those donors who have valid health insurance, right? So if someone is undocumented and then needs a kidney in the future, if at that time they do not have health insurance, they are not, unfortunately, eligible to get that safety net. If they have health insurance, then yes, they can. So just to answer that question, in terms of recipients, I don't know if you have.
So for recipients, we at this time are only evaluating people with active insurance. So emergency Medicaid for anybody who can obtain it is unfortunately not adequate for the transplant procedure in terms of post-transplant medication costs and some of the actual procedure costs. So really, we don't want to create further financial burden is really the main thing. It kind of falls down into a safety concern for us, as well as a hardship for the patient. If you're able to go through the marketplace and get non-emergency Medicaid, then we will work with you at any capacity. But it does come down to coverage in a lot of ways.
I have a quick question about, it's on the lines of that. There's a new ruling that it's when a person becomes of a certain age and they're undocumented with ECAID, then it turns over to what's called regular Medicaid. So I don't like to put an age on it, but what's the cutoff age for transplant?
Right.
In
So
terms if they get it?
Yeah. So the insurance policy, it's at 65. It's when it turns over. You can get straight Medicaid if you're undocumented. The other portions of the assessment that we need to be cognizant of, though, is that because they are receiving Medicaid does not mean that they have adequate status for other benefits or finances. So you do need to, again, still complete like the full psychosocial evaluation to make sure that they have like stable housing and adequate recovery plan. We don't see that many of these patients come through. But that is something that we do have to, dig into a little bit more.
Okay, thank you.
Yeah.
I do see a question in the chat about if a patient has a potential donor that is out of the country, would we help bring them in for evaluation? So we do have number of patients that come and tell us, I have a family member back home in my country, they're interested in donation. Yes, they can apply. The first step is always to complete the application. Once they complete the application, a member of our team will reach out and talk to them. We have to speak to them directly. We can use an interpreter if needed, but we need to make direct contact and talk to them. After we have that initial phone conversation, the family member that wishes to donate has to get preliminary blood work back home. If that looks okay, then we can provide a letter, a visa letter, just a letter that they can use to process their visa. That is the only thing that we can do to help them in the process of coming to be evaluated. And you know, we explain this to patients. Sometimes they think, you know, we can make it happen. We can only provide the letter, and then it is up to that family member to go to the consulate back home, like whatever the process is in their home country to do that. What we know is that it tends to take a very long time. So while we will tell the patient, you know, this is what we can do, we also highly, highly encourage them to continue to explore and talk to family here, and see if there is anyone here that can come forward as a potential donor. But yes, we can help with writing a letter. We also, it's important for patients to understand that we can do that only if we speak with the recipient team, and the recipient team lets us know that, yes, this is a transplant candidate and we can move forward with doing this. If the patient just came in for their evaluation, then, you know, we're going to hold off until the recipient team lets us know, yes, we can move forward. The other important thing, and thanks Helen for reminding me, is that the patients and the potential donor need to also understand that if they come from out of the country, they are not entitled to any of the financial programs that exist for donors here. Unfortunately, those programs, in order to be eligible, you need to reside in the US. And for some programs, you need to be a US resident or citizen. And also the costs related to travel, lodging, anything like that, that's all those costs are costs that have to be then covered by the donor and or family. That's not something that we can help with or the programs can help with. And with all that said, I will say that we have had successfully a number of patients who have had family members go through the process, get a visa, come, go through the evaluation, and successfully donate and then go back home. And also the family needs to understand that once they come, they go through all that process. They also then have to undergo the evaluation here. So sometimes a donor can, you know, get their visa, come, do the evaluation, and then we discover, you know, that unfortunately they cannot be approved for donation. And so then they just traveled and won't be able to donate. So all of those things are things that we discuss with the recipients and make sure that they and the potential donor understand.
Wonderful. Thank you so much for that answer. I think that was extremely helpful to understand the process. Are there any other questions from our attendees today? I don't see anything else in the chat. Again, you can also unmute if you'd like to ask the team something. All right, so I am going to move to the next slide for a second and review the continuing education one more time. This session has been approved for continuing education through the California Board of Nursing. So that means there's 1 CE credit available for registered and practical nurses, dialysis technicians, and dietitians today. Attendees are going to be receiving information from me within 10 business days on how to access that certificate. And then this slide is a short post-session survey. If you could utilize your smart device, and then I'm also going to put the link in the chat for us and the Montefiore team to receive some feedback on the session today. That would be extremely helpful. to gauge future offerings. If you give me 1 second. And then did you have another question? Yes.
If you could pop my email in the chat, for some reason it's not letting me type.
Yes.
And for anybody who I do work with on like the recipient side of things, just as a brief heads up, we do try to send out quarterly reports now for the patient updates. Our data tech is currently out. So if you do have any issues or you need updates, we might be running a little slower on that, but you can reach out to the email there to me directly or my phone number, and we can work something out, get you those updates.
All right. I have both Luke's email and the post-session survey link in the chat for our attendees to use. I'll hang on for a couple more seconds if any more questions come up. But if there's no more activity, we're going to close out for today.
Thank you.
Thank you so much, everybody.
Perfect. All right. It looks like we're good to go for today. Thank you guys very much for this offering. And we'll talk soon.
Thank you.
Great.
Bye-bye.
Thanks. That was good.